I am Dr. Sharma, neurosurgeon. We carried out a detailed analysis of the clinical effects of cell therapy for dorsolateral spinal cord injury. Spinal cord injury, which is often caused by road accidents, fall from heights, etc., causes severe neurological damage. This results in paralysis, which severely affects the quality of life of the patients. Recovery from spinal cord injury is difficult since the injured spinal cord loses its ability to regenerate the lost or damaged cells and subsequently re-establish the functioning neural connections. Currently, therefore, there is no cure for spinal cord injury. Cell therapy is one of the most promising treatment strategies available for spinal cord injury. It focuses on resupplying the lost or damaged cells with progenitor or stem cells, further leading to axonal growth, remyelination of axons, and reduction of neuronal degeneration. These cells have the capacity to mobilize and exert their reparative effects at the site of injury. In the murine model, injected cells have shown to migrate and attach to the injured neural tissue. Within 3 weeks, the cells release trophic factors to stop the degeneration of neurons and glial cells and stimulate the differentiation of neural stem cells in the injured spinal cord tissue. They enhance angiogenesis and contribute to the neovascularization by producing signaling molecules such as vascular endothelial growth factors and fibroblast growth factors. They have been found to replace white and grey matter with neural and axonal regeneration, astrocyte proliferation, myelination, neovascularization, further leading to functional improvements in animal models.
The study design includes 110 patients of chronic spinal cord injuries, both traumatic as well as non-traumatic paraplegics. The process includes administration of autologous bone marrow derived mononuclear cells intrathecally. The process of isolation and administration of autologous bone marrow stem cells comprises of first stimulating the bone marrow using granulocyte colony stimulating factor 48 hours and 24 hours prior to the bone marrow aspiration and harvesting. Followed by that 100 ml of bone marrow is aspirated from generally the iliac spine, either anterior or posterior superior iliac spines under local anesthesia. If necessary, general anesthesia may be given. The harvesting of the bone marrow is followed by separation of the mononuclear cells using a gradient separation method. The mononuclear cells are checked for viability as well as CD34 count by using FACS sorting. The stem cells of the bone marrow derived mononuclear cells are injected intrathecally. The rule of thumb generally used is body weight into 10 raised to the power 6. This is done using a lumbar puncture procedure using epidural catheter or a 18G Towie needle, generally between L4 L5 spines. Followed by intrathecal injection of bone marrow derived mononuclear cells, the patients undergo an intensive rehabilitation procedure, which includes physiotherapy, occupational therapy, urological rehabilitation, sexual rehabilitation. This is devised as per the patient requirement and is individualized as required depending on the level of the injury as well as the duration of injury and whether it's a complete or incomplete transaction. The exercise protocol hence is personalized for each patient. Followed by this, the outcome measures that are used are generally FIM scores for functional improvement, ASIA score to see the change in sensory as well as motor levels, and objective assessments such as functional MRI and electrophysiological testing such as EMG and CV. These are done at 3 months of follow-up, 6 months of follow-up, and after that year.
The results of our study showed on a mean follow-up of 2 years plus minus 1 month, 100 out of 110, that is 91% showed overall improvements, which included symptomatic, investigational and functional. 26% cases showed reduction in spasticity, 28% showed partial sensory recovery, 96% cases showed improvement in trunk control, and all cases showed improvement in the posture and hypotension. 33% cases showed improvement in bladder management with respect to shifting from indwelling catheter to self-intermittent catheterization. 22% of the wheelchair-bound cases actually started to walk with assistance. 60% of cases whose ADLs were affected, that is activity of daily living, also showed improvement. There were other improvements in sitting balance, standing balance as shown in the graph. Objectively on Asia scale, which is widely used scale for spinal cord injury patient, 2 of them shifted from grade A to C, 1 shifted from grade B to C, and 8 shifted from grade A to B. Other objective scale which we use to measure the functional independence was the film score. Out of 110 cases, 59 showed significant change, and we also tested statistical analysis which showed a significant p-value. The graph shows film score before SCT in the 110 cases and cumulative film after SCT, and as we can see, the difference was statistically significant. Wilcoxon-Sign rank test was conducted and the p-value was less than or equal to 0.0001. It is evident that there is significant functional improvement post-intervention. Along with these studies, we also did EMG studies in which 2 showed improvement, and on imaging studies of fMRI, 1 showed a change. We did a detailed analysis of the symptomatic improvements in the 110 patients and tried to analyze the various factors which affected the degree of improvement. So we saw that younger population responds better to SCT. Chronicity wise, the patients who had injury of less than 1 year, 57% showed improvement, 60% in the 1 to 3 year group and 71% in 3 to 5 year group, and as we can see, the least response of 35% was in more than 5 years group. With level of injury, 48% showed improvement in D1, D4, 48% in D5 to D8, 64% in D9 to D12, and 41% in lumbar level injury. When we analyze the patients according to whether the patient has received rehabilitation prior to SCT, 50% of the 62 patients who underwent extensive neuro-rehab before the intervention showed improvement, and 60% of the patients who have not undergone neuro-rehab also showed improvements on the film score after the intervention. So the similarity of percentages in both the groups makes it evident that stem cell therapy independently exerts beneficial effects. So we conclude that with the multiple mechanisms of action of the bone marrow mononuclear cells, there is a reparative process in the damaged spinal cord which is exhibited in the form of symptomatic and functional improvement in majority of the dorsolateral spinal cord injury patients. Our study also reaffirms the safety and the viability of intrathecal autologous bone marrow mononuclear cell therapy. It also establishes the fact that cell therapy has the potential to augment the standard rehab therapy in the spinal cord injury patient. This study may serve as a guide to future larger multicentric clinical trials.